Okay, so this is where we left off with the superficial face. This is the distribution, basically, both cranial nerves and spinal nerves to the face. In relationship to this slide, it's color coded, so the ophthalmic branch V1 giving off primarily supraorbital, supratrochlear branches, and also this external nasal branch, which was a portion of what we refer to as the nasociliary, is given off to innervate anywhere from what we call the peak of the head, the vertex of the head, down to the tip of the nose. And then this area associated with the areoolizygoma, the cheekbone, we have this area that's designated in blue with its infraorbital and zygomatico facial and zygomatico-temporal branches that are coming down there, all the way down to the upper lip. And then this area that's designated in green with this little tag that I added in here in relationship to the orbiculotemporal branch of B3. We've got that branch taking care of the area of the upper scalp, kind of behind the zygomatico-temporal, and then coming down just in front of the ear, but including the upper portion of the earlobe, the auricle, and coming down in this area, just in front of the premolars and coming forward to the tip of your chin. Now that is V3. So the trigeminal is pretty much, from a sensory perspective, is the input for the anterior face. Okay. This posterior area of the, in particular, skin overlying the lower portion of the auricle of the ear and the area of the angle of the mandible, and back further is innervated by cervical nerve branches, in particular this great auricular nerve C2 and C3. So those are branches that we would typically see in relationship to sensations coming from as far down as the thorax. Because if you remember, one of the things with the cervical distribution that we had in regards to innervation of the diaphragm, innervation, sensory innervation coming back from the pericardial sac, and in the pleural cavity was this phrenic nerve, C2, C3, 4, and 5. So there's some overlap there. Now, the other thing that is significant here, let's see if we get this. Is this area here. Everything in front of that red line comes off of anterior rami of spinal nerves, and that's important to understand once again that when a spinal nerve branches, it branches into a very long anterior rami that comes forward as far as the midline of the body, the trunk, here the case of the neck, and behind it are posterior rami. So the posterior rami in this area is the greater occipital nerve, the third occipital nerve, and posterior rami of cervical spinal nerves that are anywhere from 3, 4, and 5, coming down the back of the neck. Okay, so those also have a relationship to the C3, 4, 5 area associated with the phrenic nerve. So sometimes neck pain or jaw pain is not associated with teeth or the head. It may be associated with referred pain from areas such as the thorax. Okay, so that's the trigeminal distribution, primarily a sensory distribution. If you remember, two of these divisions associated with cranial nerve 5 are coming from very specific areas where they are receiving their branches. The V1 branch, the ophthalmic branch is receiving its branches in the orbit. The V2 branch is receiving its branches in this area we call the pterygopalatine fossa. And I put together some slides the other day that I was sent out to you because a couple of the slides are slides that weren't noticed, that weren't annotated well, and also they weren't, with some slides that were done by new illustrators in association with Netter's text, okay? So it shows it from a variety of different perspectives. Okay, we're gonna talk a little bit about that today with facial nerve. Okay, but V2 receives its branches in the pterygopalatine fossa. Okay, Dr. Wolf is going to talk to you on Thursday in relationship to V3, primarily in the infratemporal fossa region where it receives all its branches, but also that V3 has the motor supply to muscles of mastication and a couple of other small muscles, such as the posterior digastric and the stylohyoid, and another branch we'll talk about when we get into the pharynx. That's a branch of V3 that is a motor branch to a muscle called the tensor palatini or tensor palatini muscle. Okay. So V3 is interesting division because it has both motor and sensory. Okay. Once again, the motor here, the skeletal muscle, is associated with branchial arch development, and that is associated primarily with the first branchial arch development. Okay. Now we're going to talk about this afternoon is this cranial nerve branch, the facial nerve, which also arises from branchial arches. It arises from a branchial arch that's referred to as the second branchial arch or the hyoid arch. And facial nerve starts off in another area that is a special sensory area for the most part. And that is this area here that we refer to as the ear. Now we can divide the ear into three regions. We'll be talking about it like the orbit, which we'll talk about again, like more specifics of the movement of the eyeball and so forth. Has its association with trigemimal's first division and trigeminal second division. But in this case, we're talking about the facial nerve, and we can divide this area into a external ear, okay, and a middle ear, and an internal ear. So over here, this area out here, including the auricle of the ear, okay, this is external ear, okay. Sound waves come in here in relationship to cranial nerve number 8, not 7, come in here in relationship to coming through the ear and hitting this membrane here, the tympanic membrane, or the eardrum. And then they're distributed via three tiny little bones, the paired bones, that are called ear ossicles in this region over here, where we have three bones that are called the malleus, the incus, and the stapes. And these are transmitting those sound waves from the tympanic membrane to the inner ear via the vibrations of sound waves hitting the tympanic membrane and going to an area over here where this bone, the stapes, is sitting over a window that's referred to as the oval window, which is transmitting these sound waves into a cave. We refer to anatomical term for caves as labyrinth or labyrinthine. And this cave is taking these sound waves to the organ of Corte, which is the sensory receptor for sound, okay? So we'll talk about this again with the ear, but one of the things about the eardrum, the ear ossicles, and the oval window is that the tympanic membrane is about 20 times larger surface area than the oval window. So as we transmit the sound waves through the ear ossicles, we are actually magnifying sound just with that device 20 times. And then the fact that we are going to then transmit through a fluid media in the inner ear these sound waves, that's also going to increase the dimension in relationship to sound waves, probably at least another 20 times. So just with this device, we're going to increase sound waves. Okay, so we'll talk about that more when we talk about the ear itself. But this area here, this is the inner ear, and the inner ear is receiving two cranial nerves, or transmitting two cranial nerves. Cranial nerve number 7, the facial nerve, and cranial nerve number 8, the vestibulocochlear nerve. And with the vestibulocochlear nerve, here is the cochlea over here. Here is the vestibular portion, the semicircular canals over here. And these are entities that are associated with a special sensation of hearing, cochlea, or vestibular function, balance, okay, balance. Okay, what are we balancing when we move through our environment? What's the thing that we have to carry with us through our environment that affects our ability to stay balanced? It's your head, okay? If there are problems with the vestibular system in relationship to your head posture, okay, you may just fall over, okay? So, or you may have problems where you get dizziness, okay, associated with things like middle ear infections or things like that. We'll talk about that with the ear itself. But this is the inner ear. Now the facial nerve comes in here as well. The vestibulocochlear nerve only goes to the sensory apparatus, the organ cortae in the cochlea, or the semicircular canals in this membranous labyrinth, this membranous cave area. The facial nerve goes a little bit deeper in here, and it will then come off of the area of the pons, just like the trigeminal nerve does, and it will go through this opening right here. Okay, and that's the internal acoustic meatus, okay? And it'll come into the internal acoustic meatus, and then it will have a branch that goes forward and a branch that bends backward, okay? And those branches are one of them we talked about before, but here is the facial nerve kind of coming into this area here and going forward, and this area here going backward, okay? So backward and forward, okay? And the forward branch we talked about is a rather significant branch of the facial nerve because it has two entities, one motor and one sensory, in this case special sensory. The motor entity is parasympathetic, and that's the greater petrosal nerve that is coming into this anterior split in the facial nerve. The anterior, that's the anterior branch, but also in there are sensory fibers that are received by the greater petrosal branch that have come from the soft palate, okay? And these are special sensory fibers for taste sensation. There are taste buds we'll talk about when we get into the pharynx. There are taste buds in the beginning of the oral pharynx that are associated with the soft palate, really on the border of the soft and hard palate, and they are picking up sensations, typically of taste, associated with things like alkaline substances and acidic substances, okay? So that sensation is coming back along this greater petrosal branch, okay? Now, where this bends, where this bends right here, okay, it bends forward and back, so it's like a knee, okay? And the knee, our knees are bent, in this term, a an area that bends, it's called a genicle. And in this case, this is a ganglion called the geniculate ganglion. And this is the facial nerve sensory ganglion, okay? So this will receive actually fibers from the area of the soft palate that have their cell bodies in this ganglion, okay? So that's called the geniculate ganglion. Now bending backward is a branch of the facial nerve that is also has some fibers that are both motor and sensory, okay? And those fibers that are both motor and sensory are a branch of what we refer to as the facial nerve proper. Now the facial nerve proper, we'll see, comes back behind the area of the ear. This is it here. Here's this geniculate ganglion over here. Okay. Here is the greater petrosal branch here, coming out of this slit in the temporal bone. Okay, and that slit is referred to as a hiatus, and this is the hiatus of the facial canal. So that's the greater petrosal branch with its special sensory fibers and its parasympathetic fibers that are going to synapse where? Where's the greater petrosal nerve going to synapse? Not in the geniculate ganglion, that's a sensory ganglion. Parasympathetic, sympathetic are two neuron systems, right? There's a preganglionic neuron, there's a postganglionic neuron. The preganglionic neuron in this case is coming from the pons. Okay? It's in the pons, it's a nucleus in the pons. We'll talk about this morning, that was a long time ago. But this afternoon in relationship to these nuclei and their relationship to cranial nerves. So the preganglionic fiber is coming from a nucleus in the pons. And the postganglionic neurons are where? They're in a ganglion. That's what makes the autonomic nervous system peripheral in relationship to its nervous system setup, okay? So they're going to a ganglion, and this ganglion is where? Okay, in the pterygopalatine fossa. And what's it hanging on to? It's hanging on to the maxillary division of the trigeminal nerve, okay? And in there are the postganglion neurons associated with parasympathetic innervation in the head, basically in the deep face and head, okay? And what are those fibers, how are those fibers now, the postganglionic fibers, going to travel to their respective areas in the deep face, in the orbit, in the palate, soft palate, hard palate? How are they going to get there? What are they going to travel with? What? They're going to travel with the sensory branches of the maxillary division, right? Okay. So as I told you last week, the maxillary nerve division is acting as a conduit for these postganglionic parasympathetic fibers that are coming from this ganglion and going basically to perform what we refer to as a secretomotor function, innervating mucosal glands. One of the larger glands that it innervates is the lacrimal gland, okay? So that is what's happening with those greater petrosal branches that are with that ganglion receiving this branch of the facial nerve, this greater petrosal branch. The sensory branches are not autonomic, they are just special sensory, because taste sensation is not something that you find outside of the head, okay? All right, so now we've got this large trunk coming here behind the middle ear chamber. That's where 2, 4, 9, and 10 is coming. Okay, so that large branch coming down behind the middle ear chamber, that is the facial nerve proper. And it's going to come out here Here's the mastoid process of the temporal bone. Here's the styloid process of the temporal bone. It's gonna come out of an opening called what? Stylomastoid foramen. And it is, we'll see, gonna come out and innervate muscle, primarily muscles of facial expression, another couple of muscles. It's going to innervate the posterior belly of the digastric. What I said with five innervates the anterior belly of the digastric. And it is also going to innervate a muscle called the stylohyoid. And before it comes down, it is going to innervate this tiny little muscle in here, okay? And this muscle is called the stapedius. It attaches to the stapes. It also is going to give off this branch that eventually is going to drop down out of the middle ear chamber. And this branch is important to us. This is the chordotympanic branch. And this is going to come down and join a branch of V3, and this branch is referred to as the chordotympanic branch because it's right behind the tympanic membrane. It actually runs on the inner surface of ear-ossicle referred to as the malleus. Okay, so, but this here, this is the facial nerve proper, okay? And that is going to be a motor branch associated with this facial nerve as it comes back. It's its posterior branch, okay? So here, back here, what we see over here, this is the facial nerve proper that is exiting the stylomastoid foramen, okay? Let's see if I can do this one. Never mind. Okay. So stylomastoid foramen, that branch is coming through, and that is coming through and into the capsule that surrounds this gland. What gland do you think that is back there? Here's the earlobe. So this is the back. Here's the mandible out here. So what large glandular structure lies just in front of the earlobe? Parotid. Okay. So the facial nerve is going to go into the parotid gland, and it's going to branch essentially into 5 of its 6 branches. It gives off its 6th branch really almost as soon as it comes out of the stylomastoid foramen, and that is that branch here. You can kind of see it with the illustrator's drawing right here. That's called the auricular branch. But the facial nerve, 5 of the branches are going to be given off inside of the parotid capsule. Inside of the parotid capsule, 5 of the facial nerve 6 branches, okay? And you know, for years and years, I never understood, you know, dental anatomists or head neck anatomists said the 5 branches of the facial nerve, but there are 6, okay? So there aren't just 2 zebras that bit my cousin, okay? There's a tall zebra that bit my cousin, okay? And so we've got the auricular branch, and that innervates a combined muscle that is interconnected by a large flat tendon here, an aponeurosis, between this thin muscle in the back called the occipitalis and this muscle of your forehead called the frontalis. And so they call the muscle combination occipitofrontalis, and the auricular branch innervates the occipital portion, the occipital muscle, occipitalis muscle, and the anterior portion is innervated by probably the highest branch of the 5 combined coming out of the capsule called the temporal branch. Okay, so that runs through the parotid capsule. Okay, so anything that happens in this parotid gland that is some type of disease process, which could be something as simple as parotitis. What's the common name for parotitis? Mumps. Okay? Mumps or some type of parotid tumor can affect the facial nerve. Okay? Can affect the facial nerve. The white circle here, it's over here, that is the parotid's duct. That's going to come out onto the face. We'll see that in the laboratory. And then large artery, what do you think that large artery is that is kind of caught up in the substance of the parotid gland? Internal carotid. Internal carotid. The parotid gland, we'll talk about anesthesia, local anesthesia techniques, in particular in relationship to inferior alveolar blocks and things like that. The thing that you have to concern yourself is that you don't pass out of the infratemporal fossa and pass into the parotid capsule. Otherwise, your patient's going to have a hemifacial paralysis on one side. For probably with the concentration of anesthetic that we use here, about 5 hours. Okay. So that is a problem. Or worse than that, you inject the anesthetic into the internal carotid artery. Okay. Where's the internal carotid artery going? Brain, eye, okay, so forth. So you may have, maybe slow down blood flow, the ophthalmic artery that's giving off a branch to the retina, so you may have a little blurry vision, okay. Worse than that, you may close down the circulation, or possibly cause a blowout of a tiny little vessel in the cranial bulb going to the brain. Okay. So that's something that you should know. You should always know the facial nerve and its branches, the internal carotid artery, are within the confines of that encapsulated salivary gland, so to speak, in your face. Okay, this parotid gland. This branch coming out here is the chordotympanic branch. This is this opening called the petrotympanic fissure. Okay, petrotympanic fissure. And that chordotympanic branch is coming down here to join this large branch over here. And this is that is the lingual branch of V sub 3. Okay, so that's the lingual branch of V sub 3. So the chordotympanic branch is kind of the twin cousin, so to speak, or the twin brother or sister of the greater petrosal nerve. So what kind of nerve fibers are in that chordotympanic branch? What did the greater petrosal nerve have within its nerve trunk? What kind of fibers? It had GVE, parasympathetic, okay, going primarily to deep structures in the face. And what else did it have? Special sensation for taste, the palate. This is going to join the lingual nerve. Why do we call it the lingual nerve? What is it associated with?
Tongue.
The tongue, okay? So the trigeminal nerve is not a special, does not have special sensory, but it has general sensory, and it's going to receive general sensations from the floor of the mouth, some of the lingual mucosa, and the dorsum, the top of the tongue, okay? But it is now serving as a conduit to bring this chordotympanic branch down to a couple of larger glands in the oral cavity. One of them is the sublingual gland, and the other is the submandibular gland. Okay, and I think we'll see in one of these images, but if not, you'll see with Dr. Wolf. There's a ganglion there called the submandibular ganglion that actually is interconnected now to this trigeminal branch referred to as the lingual nerve. Okay, and then it's going to have special sensation coming back in this nerve trunk from the tongue, associated with taste sensations like sweet, sour, salt, alkaline, acidic sensations associated with the process of taste. Okay, so that's the chordotympanic coming out of that petrotympanic fissure. Okay, remember the petrous portion is the petrous portion of the temporal bone. The tympanic portion is that portion of the temporal bone that kind of surrounds the external acoustic opening, or the tympanic membrane. And over here, what's going into the mandible? What branch of the mandibular division would be going into the mandible? Okay, it's the V3 or mandibular branch, that's the inferior alveolar. Okay, that's the inferior alveolar. Okay, so these are the branches of the facial nerve. The facial nerve proper actually has both SVE and GSA. What's the GSA? What did I tell you about skeletal muscles in relationship to GSA? What type of general sensation are they sending back to the nervous system? Proprioception. Kinesthetic sense, movement associated with these skeletal muscles, okay, muscle spindle receptors inside the skeletal muscles, and so forth. So this is a GSA type component. And the other thing that the facial nerve proper has is SVE. Why is it SVE? It's innervating these skeletal muscles. Where do these skeletal muscles develop from?
Somites?
Well, there's, S is for special, V is for visceral, E is for efferent or motor. So what kind of, where do these skeletal muscles develop from? From branchial arches, in this case from the second branchial arch, okay? Gill arches. That's why they are visceral. The gill arches are originally in organisms or vertebrates that came from the sea were associated with their respiratory system, okay? Or this visceral tubular entity associated with their being able to breathe in water, so to speak, okay? So they're special. Nowhere else in the body do we have skeletal muscles that develop branchial arches, okay? Only in the head, okay? Special, visceral, because these are muscles that have something to do with the face or jaws, okay? And pharynx, we'll see as well, okay? Skeletal muscles, no different than somites from the standpoint of their histology, but different from their point of origin, okay, or their development. So we've got the auricular branch going to this occipitalis muscle. We've got a temporal branch, which pretty much goes, we'll see the muscles that are around the optic region, around the orbit, associated with the upper eyelid in particular, but a little bit of the lower eyelid, and the temporal branch innervating this anterior portion of this occipital frontalis, referred to as the frontal muscle, frontalis muscle, okay? Zygomatic branch, what's the zygoma? The cheekbone, okay? So what we've got muscles we'll see in our illustration this afternoon that are coming off of or very close to the cheek, okay? Buccal also refers to the cheek, okay? But it's a little bit deeper. And now a lot of those fibers are going to probably the thickest muscle of facial expression referred to as the buccinator. It receives a lot of innervation from the facial nerve. And some people will consider the buccinator kind of an accessory muscle of mastication, because when it contracts, you know, you have these vestibules between your cheeks and your attached gingiva or your dentition, and that helps to push whatever food gets trapped in there back up onto the occlusal surface to chew. So same thing, helps in the process of chewing. But it also can help you whistle, you know, and other things, you know, pucker your cheeks, things like that. Okay. The mandibular branch, okay, we've got muscles of facial expression that are associated with the mandible, okay, that are moving soft tissue structures around the mandible. And then the cervical branch is really to one muscle. It's one of the larger branches of the facial nerve. And that is coming down to this muscle here. I call it the lizard muscle, because it just, well, this is the only thing I know you can do with it. You know, it's going to make yourself look like a lizard. But the platysma muscle, which also has an attachment to the mandible, okay? So one of the things we'll talk about as we move here, we're going to go to the muscles themselves and look at some of those in relationship to that. But facial musculature is given the name muscles of facial expression because when they move, their point of origin is from bone, from some facial bone, okay? But their insertion point is soft tissue. And these soft tissues surround these visceral openings, the oral cavity, the nasal region. They surround the orbit, not so much a visceral tubular entity, but it's still kind of thrown into this mix. And they control the openings which they surround. So facial expression is just a consequence of these muscles moving because of their soft tissue relationship. As they move, they cause us to create expressions, okay? When neuro, we'll talk about a disease like Parkinson's disease. In Parkinson's, and many times you've seen the patient, they have what's called a mask-like expression. When they talk, their facial muscles are not stimulated to contract. So that it's like just a face with openings, but no expression. They have this kind of fixed expression. So there are diseases that you can pick up on when you're looking at your patients that are coming in here or in the future, that they might have something wrong associated with this, other than paralysis associated with injecting into the parotid capsule or some type of injury to the face. Okay, so here are once again coming out front, here coming through the parotid capsule. We have these upper branches in front of the earlobe, starting with a branch that kind of goes behind the earlobe to a muscle called the occipitalis, gets kind of covered up by the lower portion of the earlobe. And then these 5 large branches, the temporal branch, the zygomatic branch, the buccal branch, the mandibular branch, and the cervical branch. The cervical branch is probably one of the easy ones to define because it goes only to this underside of this very thin, flat muscle called the platysma. And then these cervical muscles down below and behind. So, over here we've got temporal, zygomatic, buccal, mandibular, and cervical. Okay. Over here, these 5 large branches, and then back here, this muscle is going to receive this branch from under here, and that's the auricular. Okay, and here we see him in this drawing out of McMinn's Color Atlas. It's an atlas that I recommend highly, in particular in ordering the laboratory material, because he's got such a nice head demonstration photographically. So he's got all of these branches out here, but one of the branches is missing. Which one's missing?
Auricular?
Yeah, auricular's probably missing. He's got 2 branches missing. What's the other one that's missing? What comes down here from the mandible and covers this area? Okay, the cervical, platysma. There's no platysma, so there's no cervical branch showing in this illustration. Okay, so muscles of facial expression. Once again, these muscles, from the standpoint of their motor innervation from the facial nerve, the motor component here is special visceral efferent, okay? Special visceral efferent. These are muscles that develop from the second branchial arch. They all have a proprioceptive feedback that's GSA, okay? That's associated with telling the nervous system what the muscles are doing. If we don't know if the nervous system doesn't know what muscles are doing, it's very difficult for it to help us in regards to having contraction in those muscles, and what we refer to as a synergistic activity, where muscles are working together and get the type of movement that we want. This is throughout the body. So we have this occipitofrontalis, from the occipitalis to the frontalis, that is interconnected by this this tendon called this flat tendon called the epicranial aponeurosis, or another name for it is the galla aponeurotica. The galla aponeurotica. Then we've got muscles that are in front of the earlobe, on top of the earlobe, and behind the earlobe that are called anterior, superior, and posterior auricular muscles. Can any of you wiggle your ears? All right, you saved yourself. But for humans, you know, we don't move our earlobes around, but our earlobes are important for capturing the sound. These auricles are important for capturing the sound waves. If they're not there, the sound waves are just bouncing off the side of our head, and it's much more difficult to hear. So anybody that's had any type of developmental defect of their external ear, or any type of trauma that has caused deformation in the external ear, they have much more of a difficulty in relationship to hearing. But you've ever watched quadrupeds? You know, it's tough. I've got a retriever. He's got floppy ears, so it's hard to see where he's moving his head. But there are other dogs, cats, cows, horses that you can see them moving their ear auricle around to try and find out where the sound is coming from. To try and find out where the sound is coming from, and that's being aided by these three muscles: this anterior, superior, and posterior auricular muscles. Then there is a muscle that surrounds the orbit, the outside of the orbit. So it basically orbits the orbit. So it's called the orbicularis oculi, the muscle that surrounds the orbit. On the top part of your brow ridge, your superior ciliary arch here, which is part of the frontal bone, there's a muscle that's covered up by this orbicularis oculi that is called a corrugator supercilii. So it allows you to kind of squeeze and fold your upper brow ridge, you know, to create some type of expression in relationship to a facial expression associated with your upper orbit. And then there's a muscle that comes off another muscle here from your frontalis, and it comes down here to the bridge of your nose, okay? Or this process coming off of your face. So it's called the procerus muscle. And then there is a muscle down below that that comes along the side of the nose. These are muscles that we'll see in the lab, called the nasalis. And when the nasalis pulls, it pulls from the middle of the bridge of the nose out from these openings here that are called the ala of the nose, that are on the outside of your nares, your opening of your nasal cavity. So it flares that. Now, that also creates a type of facial expression. It's usually demonstrated either graphically with cartoon illustrations of bulls when they're snorting, or when you see another organism outside that is kind of disturbed by what it sees and is getting angry in its environment, and it flares its nostrils. It flares its nostrils. So this nasalis works along that. Zygomaticus major and minor have to do with the control anywhere from the lateral corners of the mouth where the upper lip meets the lower lip, or also the upper lip in particular to the zygomaticus minor, helping another muscle called the levator labii superioris aliquinesi raise the upper lip. And then, you laugh now. Aliqui refers to the ala of the nose, okay? So it pulls from the corner of the nose. There are three muscles that join. One of them is the zygomaticus minor, joins the levator labii superioris from the lateral side. The aliquinesi is along the lateral border of the nose, your external nose, and that joins it from the medial side. And those three muscles together help to elevate the upper lip. Okay. So then we've got another muscle that orbits the oral cavity, orbits the mouth, and that's called the orbicularis oris, okay, the orbicularis oris. Okay. So then there's a muscle that sometimes you can see, okay, that runs along the top border of this large flat muscle called the platysma. But this muscle kind of comes off the top edge of the platysma and comes to the corner of your mouth, horizontal to the top of the platysma, and this is called the rhizoridus. What is rhizor? What does the term rhizor refer to?
To laugh.
To laugh or clown. Okay? So you ever seen clowns when they put on, you've seen clowns, when they put on their makeup, they usually enhance this lateral extension from the corner of their mouths to give them this kind of broad laugh or smile type of impression. Okay, so that's the rhizor. It's very tough to show. Sometimes we can get a good one, sometimes not. Then there are these two muscles, one above and one below at the corners of the mouth. The one that's above is called the levator anguli oris, and that helps you smile. And one that comes and pulls down the corner of the mouth, and that helps you frown. Okay? So, I don't know what kind of mood you are in today. What you have this morning? You all look depressed.
Diseases of GI system.
The what?
The diseases of the GI system.
Oh, yeah, that can make you sick, can't it? So then we have a muscle that its role is to pull the lower lip down, or the depressor of the lower lip, depressor labii inferiors. Okay? Then we have a muscle that is called, it's kind of the pouting muscle, where it kind of pulls out and forward the midline of your lower lip. I think I have this in here. I've got a grandson that several years ago, I just caught him frowning, you know. It wasn't because of me, it was probably something that his parents said, but he was great at using this muscle. He was one of the best pouters I've ever seen. So I caught it with my iPhone and, you know, brought it in here. I had to get him to sign off on it, you know, release, but that's the mentalis muscle, right in the midline. Kind of attaches from your menton, your chin button, to each side of the center of your lower lip. Okay? So, then the platysma definitely, I mean, if you put tension on it, it's going to put some downward pressure on the mandible. But from the standpoint of our perspective, it doesn't do too much for us. I mean, from the standpoint of muscles of the facial expression, it can give you this kind of distorted facial look that may concern somebody that you're standing in front of, you know, something like that. But it primarily doesn't do a lot, although it can assist in, I guess, opening the mandible, pulling it down a little bit farther. Okay, so unique facts about the muscles of facial expression. They are, first of all, this is the only skeletal muscle group that, opposed to be surrounded by deep fascia, like we saw in the abdominal muscles, okay, or other muscles of the body, is surrounded by superficial fascia. What's the difference? Superficial fascia contains fat, okay? And that, in all honesty, because I did this dissection last week, that you have to be careful that you don't go too deep, because not only will you take the fat off, but you'll cut the muscle free, okay, from the skin. Remember, it's just attached to the skin. So they are contained within superficial fascia. That's the only skeletal muscle group that is basically surrounded by superficial fascia. And they have bony origins and soft tissue insertions. Okay? Bony origins and soft tissue insertions. Okay, so what we're seeing here is just, this is a composite drawing that is out of one of the oral surgery texts. And what it's going to show, there's muscles of mastication. You see there are points of attachment from bone or to bone These attachments here, however, are the points of origin of the muscles of facial expression, okay? Of the muscles of facial expression, and that's what, there was an illustration that I used when we talked about the skull that kind of showed this as well. So, you know, mascatory, so what muscle is this? Okay, what muscle is this? Okay, what muscle is this? If you can't read it. That's a lateral pterygoid. This is the medial pterygoid, okay? So everything else in front, and that's another thing, okay? In particular, when you're taking a practical exam, the muscles of mastication are behind the muscles of facial expression, or vice versa. The muscles of facial expression are in front of the muscles of mastication. Okay, so here's an illustration out of this Chemo book that I recommend, edited by Eric Baker, now it's called Anatomy for Dental Medicine, or Anatomy for Dentistry, and it's a good book. The second edition, they really didn't have to do that. I don't know why they did it. They try to convert it into an entire anatomy text. It also has a lot of neuro in it associated with dental medicine. Eric is at NYU, okay? But the Chemo illustrators are some of the best illustrators I've seen anywhere in relationship to this. Even in some cases better than Netter, because they give a real lifelike appearance to the structures that they see. Now, we're gonna look at a face in the laboratory, okay? That we are gonna struggle with seeing the muscles at all, okay? But here these Chemo illustrators got rid of all of the fat and just drew in the muscles. This is called artistic license. You can do this if you're an illustrator, okay? It's tough to do if you're an anatomist, although we'll see a McMinn drawing where he did a pretty good job of it. So we see these muscles from top to bottom. We see this frontalis muscle on the forehead, kind of split into the left and right, and coming down over the bridge of the nose in the midline is this procerus muscle, and then down below the procerus, coming out to the lateral aspect of the nostrils, is this nasalis muscle, and then we have this very sophisticated named muscle, this levator labii superioris aliquinesi, okay? With here is the aliquinesi portion, the middle portion is the levator labii, and then this portion coming out from this muscle that rings the orbit is the zygomaticus minor. This is a muscle that sometimes students kind of get confused with, because this muscle here, coming down to the corner of the mouth, is zygomaticus major. Over here, both of these muscles have a point of origin on the zygoma, the cheekbone, hence their name, okay? And in between them, typically you can see this muscle coming down to the corner of the mouth above, that's the levator anguli oris. And then coming around here, the orbicularis oris. Now, this is kind of, when you look at this in a textbook, you get this nice impression that you should see this wide band, just like you see in the orbicularis oculi, but that's not where it is. It's actually right inside of your lips. So when we dissect, if you ever dissect for me, I'll show you that. It's just inside of the lips, going around the border of the lips. This is to, keep your mouth closed. I think I did this before. Open your mouth and try and swallow. Not easy, is it? It's not very easy to do that. Think about that if you've got a patient that's got a circumscribed open mouth, okay? So we should probably talk about a little bit of facial growth. But these lips are important from the starting point of early development in a child, but also in the adult. You need to have your mouth closed to swallow effectively. Otherwise, the tongue is going to wind up allowing the food to go out of your mouth and onto the, either onto the plate, the floor, or whoever's sitting in front of you. Okay. Here's this large platysma muscle. Now I want you to look, this large muscle used to have a name called triangularis that attaches to the lower corner of the mouth that is now, typically it's called the depressor of the corner of the mouth, the depressor angularis over there. And this muscle here, this is the platysma. So the platysma doesn't really cover over these muscles in the front, but it does come in behind this depressor angularis and come down into the neck, okay? But then it has a close relationship with this muscle that actually has its point of origin underneath it. This is the depressor labii inferioris. Depressor labii inferioris passes underneath depressor angularis. We'll see that in the lab. That came out fairly well. Then here's the mentalis muscle coming up to the middle of the lip, okay? And those are basically the muscles' facial expression. And there's one here that you don't particularly see on your left, okay? He shows it a little bit here on the right. This deeper muscle we'll see is covered by an encapsulated fat pad called the buccal fat pad, okay? The buccal fat pad. And that buccal fat pad covers this deep muscle that attaches to your upper jaw, upper alveolar process, and your lower alveolar process. Actually, you see you haven't taken prosthetics, right? Okay. There's a ridge on the outside of your mandible. It's called the external oblique ridge, or the buccal ridge, okay? That's where the lower portion of the buccinator attaches. But that end actually comes inside towards the pharynx. We'll talk about it when we get into the pharyngeal region in a couple of weeks. And that is attached to a muscle called the superior pharyngeal constrictor. So an interesting muscle, that's your deep cheek muscle. It comes in there. Okay, so here, this is out of an anatomy textbook. This is Clinically Oriented Anatomy by Keith Moore. It's probably one of the most widely accepted anatomy texts right now. It's really grown over the course. It came from a textbook years ago that was called Grant's Anatomy. Okay, called Grant's Anatomy. So he has actually taken it and become a lab. Grant's lab was in Toronto. Any of you Canadians? Okay, so you got to be careful, especially with Dr. Whitting. He really has it out for Canadians. But here's a guy that is using these different muscles to create these different facial expressions. You know, and this is illustrated in that textbook. So if you want to get a kind of a cleaner view of this, it's in this 8th edition of Keith Moore's textbook. There he is. That's Sandy. That was 5 years ago. You probably get pissed off. You know, I was still showing you this, but you can see how he's pulled the lower center of his lip downward and forward, or with this mentalis muscle. Just did a really good job. Just did a really good job. I have a colleague, actually a colleague and mentor, who actually many years ago, what he did in one of his illustrations, and you know this was not digital photography, but this was camera photography. He drew on his own face. He was an excellent artist as well. His name was Dan Vernon, a Lowell maxillofacial surgeon. He drew on his face the positions of the muscles of facial expression, and then had his assistant take a photograph, and then he used that in his lecture to demonstrate these muscles of facial expression. Very clever guy, actually very bright, and very dedicated illustrator. Okay, so here looking from the side, here we see this muscle here, and there's some issue that kind of gets left out of the textbooks associated with this anterior and the superior auricular muscle here. It really is talked about early on as we're talking back, if you've ever looked at Gray's Anatomy, not Gray's Anatomy for students, that Dr. Down at Cleveland Clinic, Richard Drake edits, but Gray, Henry Gray, okay? And there's a muscle that sits in this fascia, and it's called the temporoparietalis. Temporoparietalis. And it is basically the union of the anterior auricular and the superior auricular. But someone then later on down the line, and a lot of the other anatomists picked up on it, they just divided it into three muscles, an anterior, superior, and posterior auricular muscle controlling the movement of the auricle of the ear. Okay, but here we see this zygomatic, in the black arrow, the zygomaticus major, and with the red arrow, the zygomaticus minor, and helping to form this muscle called the levator labii superioris aliquotis. And I'll ask you a question on the test, okay? I'll say, or I'll point this out on a practical, and I'll say, what's the whole name of this muscle? The entire name of this muscle. Okay, so levator labii superioris aliquotis. It's kind of like a rhyme. Okay, but here they are in this McMinn illustration, also showing facial nerve branches here crossing over this muscle. They cross over the masseter muscle. Here's the parotid gland. These are actually parotid lymph nodes covering up the parotid duct. Okay, these are parotid lymph nodes. Don't see a submandibular gland. They took that out. This is the same illustration they used that does not have a platysma muscle, so there's no cervical branch. But there is a mandibular branch, and the mandibular branch many times there is a upper portion and a lower portion, and they call this lower portion because it runs along the border of the mandible. They call that the marginal mandibular branch. Marginal mandibular branch. And then all of these fibers here coming across, this is the facial vein. This is the facial artery. And that's usually the position they take. The vein is always behind the artery. And they are crossing over this muscle, and here the buccinator muscle. These are couple branches. And then it's a little bit difficult to see some of the zygomatic branches, but we can hear zygomaticus major, zygomaticus minor, levator angularis here. They're coming through this little space and innervating all of these upper lip muscles and also the orbicularis oculi. And then these fibers here are coming up to innervate the upper portion of orbicularis oculi, and then way up on top, the frontalis muscle. Okay. Slide this in. Oh, things we do. Okay. Okay, so there's more. Tell you what, take a break. Morphologic differences, I think we've talked about this before. Morphologic differences in gender, okay, associated obviously with the face. So if we go through, so in males have a more prominent upper face. So larger foreheads, typically more bulbous foreheads. They have a protruding labella, okay? This smooth area on the midline between your orbits is kind of flat and smooth, and it protrudes and it creates a notch-like area. Run my finger through here, through this notch, this labellar notch. In relationship to that, they usually have a face which is more what we would call, and they talked about classes, classes of eugnathic or orthognathic cases, or retrognathic, prognathic cases in the facial growth yet. Okay, so more retrusive. That's more of a face that's more what we would call class 2 or retrognathic in regards to their upper jaw typically usually appears to be more forward in position. Okay, they have a broad nasal aperture. They have a larger airway than females of their same cultural group. And they have large mastoid processes of the temporal bone, and they have short styloid processes. With the females, they have more prominent cheekbones because I mentioned to you a few minutes ago, this area where we have an encapsulated fat pad, called the buccal fat pad, that sits over the buccinator muscle. In the females, you have less of a fat pad, and this fat pad takes a position over the buccinator muscle, which is just below your cheekbone. So what happens in the females versus the males is the males' cheeks are typically more bulbous and do not show much of the zygoma. Females, because of the smaller fat pad, that area there is a little bit more depressed, and therefore your cheekbones are more prominent, okay? Cosmetic industry says if you want to enhance your female appearance, you should put rouge on your cheekbones, okay? Hence, you know, anatomy of commercial industry, so to speak. Also things with your eyebrows, okay? Okay, so they have a flattened glabellar region. It's just a smooth transition from the midline of your frontal bone right down to your bridge of your nose. So no notch. There's no glabellar notch. It's flat and smooth. Okay. More prominent upper jaw, actually. So they are actually a little bit more, sometimes appear retrognathic. In a female, it's a little bit more female to be more retrognathic, okay? Although your orthodontist doesn't want to see that, okay? Your orthodontist wants you to be eunathic, where you have this little bit of overbite and overjet, so to speak. Anterior protrusion and vertical separation, okay? They have smaller nasal apertures in the same cultural group, well, less pronounced supraorbital rims. They're more knife-like. They're very sharp. And once again, smaller, more retrusive mandibles. And mandible in this case is also more retrusive, okay, in relationship. So this is some of the gender differences that we see in this. And they have longer styloid processes and less pronounced mastoid processes. Okay. There's actually a condition that's usually seen in females where there's calcification of a ligament we talked about called the stylomandibular ligament between the styloid process and the mandible that sometimes leads to pain back here that's sometimes misconstrued for temporomandibular joint pain, or definitely it's construed as jaw pain, where this ligament starts to get ossified. Okay. So this is a 20-year-old male. This is my son. This is Sammy's father. Okay, and you can see here that he has, you know, his cheek area is more bulbous. Okay, he's a little bit more retrusive in his maxilla, but he's pretty much eunathic. But that's hard to say because he had orthodontics when he was younger as well. Okay. And here's a female, okay? This is what you see in every dental ceramic ad. I don't know how many ads she did, but they don't show somebody with crooked, discolored teeth, okay? So this, in this case, I think this was an ad for porcelain veneers. Okay, I doubt if these are veneers in this young lady. Okay, if she did, if it was, then she really screwed up when she was younger, because these look extremely natural. Not that you can't get that effect, but one of the things you have to worry about with veneers is not the immediate placement. You have to worry about a year from after placement and further, because then the margins of the veneers, sometimes the gingiva starts to pull back, and you leave this thing, and that's ugly. So when you're doing things like this, you got to think of all of that, because if you create a situation in your patient that makes them look worse than they did before you did your prosthetics, okay, they'll tell you about it, okay, and they'll be the last patient you see in that line. Okay. or they'll make you do it over. All right, but you can see how, you know, her upper cheek, it's kind of fogged out because of the area of the stippling in the image. But she's covered up pretty much in her cheek, and you can see see this area up here, where she's got this red mustache. Okay, but up here, kind of see this zygoma sticking out. So that's a much more female appearance, even with my lack of artistic skills. Okay, and you gotta be careful. You gotta be careful on weekends. Okay? Okay, so, I mean, this guy was a giveaway, but this is from, have you ever seen the play Kiki Boots? This is one of the actors from Kiki Boots, okay? And these, we're all gender reversal type individuals, okay? So this guy was playing a woman, but if you miss this one in a bar, you had too much to drink, okay? All right, so very large nasal aperture, okay, very large nose, bulbous supraorbital rims, a glabellar notch, okay? This isn't exactly the young lady that the gentleman might be looking for in a bar. And he's also very tall, you can see, he's at least a foot taller than I am. So he might have played basketball. Okay. All right, so let's move on to another topic here. We'll talk about the vasculature more in the lab where you can see it, but let's, I want to bring down another file. I'll just close this one. Okay, so let's talk about this very scary topic.